Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Photodynamic therapy. It is nothing but a type of phototherapy which utilizes photosensitizer plus visible light to induce photooxidative reaction, which is the main principle behind this photodynamic therapy, which generates reactive oxygen species. In the name itself we can see reactive oxygen species, particularly singlet oxygen, which leads to cell cycle arrest and cell death of cancer cells. Our main aim behind photodynamic therapy is killing cancer cells. This is achieved by the principle of photooxidative reaction using both photosensitizer and visible light. Coming to properties of an ideal photosensitizer. It should accumulate well in target tissue only. It should get photochemically activated, absorbing this light efficiently at clinically relevant wavelength. What is this meant by clinically relevant? The light which is not harmful alone, it is clinically relevant. If it combines with our photosensitizer, it has to be dangerous to cancer cell only. So it is clinically acceptable. It should have rapid clearance with minimal dark toxicity. This photosensitizer should get activated when exposed to light only. If it is getting activated even in the absence of light and giving any harmful effects, that is called dark toxicity. So it shouldn't have any dark toxicity. It should get rapidly eliminated from the body after use. If it is inside the body and we are going to work and exposing to light, we may get harmful effects. So without that, we have to be eliminating the photosensitizer from the body as fast as possible. These are all the ideal properties of photosensitizer. Examples of photosensitizers: porphyrins, which we are going to study in detail, hexapyrins, chlorines, phthalocyanins. Photodynamic therapy is of two types. One is systemic, one is topical. Topical photodynamic therapy is non-invasive, which means it does not do, we are not doing any harm during the procedure, like breaching the skin or inserting instruments into the body. So we can do multiple times without any cumulative risk. It will be done very fast, so no need to admit the patient. We can be done on OP basis. Coming to our proper topic, topical porphyrin photodynamic therapy. It employs the principle of heme cycle. I already told you, main principle is photooxidative reaction. Before that, this porphyrin photodynamic therapy will employ first principle as heme cycle. Why? To convert the applied prodrugs. What are these prodrugs? ALA, methyl ALA, for aminolevulinic acid in the target tissues into protoporphyrin 9, a potent photosensitizer which when combined with visible light will kill cancer cells. It has a T-half of 1 to 2 days. So it will get rapidly cleared from the body within 1 to 2 days. It reaches peak in a short period of time, only 3 to 6 hours. After 3 to 6 hours, it gets accumulated well and reaches its peak, and when we expose these cancer cells which have protoporphyrin 9 inside them to UVA light using Wood's lamp, it will emit crimson red fluorescence, 15 times more fluorescence than surrounding normal skin. So we can easily delineate the tumor margins. Here this UVA light is just for diagnosis, not photochemically activating protoporphyrin 9. Here protoporphyrin 9 is just fluorescing, so it is not for therapy, it is just for diagnosis. So it is called photodynamic diagnosis using Wood's lamp. This meme I have already posted in my Instagram page, Wood's lamp diagnosing cancer cell in photodynamic diagnosis only, not for therapy. Next, what are the reasons for protoporphyrin 9 accumulating in diseased skin only, without accumulating in normal skin and without showing any effect on normal skin? How it is possible? Because the skin overlying the disease have more stratum corneum permeability, and cancer cells obviously will have more metabolic activity. Because of this reason, there will be change in pH. Cancer cells pH will be just opposite to normal cell, like more alkaline pH inside the cell and more acidic outside the cell because of Warburg effect. Why? It is useful for its multiplication, metastasis, survival and growth, which normal cell no need. Cancer cells will live life long, but normal cell will die. So for its lifelong survival, there will be some changes in cancer cells. We are utilizing those properties of cancer cells to kill cancer cell itself. Nothing is impossible in science. Now, cancer cells will have protoporphyrin 9 producing enzymes more. So, we are employing heme cycle because of this reason. Reduced ferrochelatase enzyme. This iron is used by ferrochelatase enzyme to convert protoporphyrin 9 to heme. We all know in heme cycle. So if ferrochelatase enzyme is deficient, protoporphyrin 9 will not convert into heme and it will get accumulated well. That is the desired thing we want. These are all happening in cancer cell itself. No need to do anything. But anything we can do by ourselves to even more increase prodrug uptake and protoporphyrin 9 accumulation in cancer cell to be our therapy effective. Yes, we can do penetration enhancing using dimethyl sulfoxide and physical methods, which also increase penetration of our prodrug like microneedling, laser pretreatment. And we ourselves, if we induce iron deficiency using iron chelators like EDTA, desferrioxamine, this ferrochelatase enzyme won't act properly and our protoporphyrin 9 will get accumulated well, which is the desired thing we want. Coming to procedure proper. First we have to prepare the lesion. If it is hyperkeratotic or crusted, we will apply soft white paraffin 1 to 3 days prior to soften and to remove surface keratinous debris. Now after lesion preparation, we have to apply prodrug, nothing but ALA, methyl ALA, including a rim of at least 5 to 10 mm of normal skin under plastic occlusion. This plastic film is transparent, it will allow sunlight. So if the lesion is in sun exposed sites, we have to add an additional dressing which is opaque to sunlight. Why? To prevent premature photochemical reaction. When we irradiate with visible light, it has to get photochemical reaction. To prevent prematurely happening, we are adding an extra dressing which is opaque. We have to wait 3 to 6 hours. We all know very well what is the reason behind this waiting period. To get peak accumulation of protoporphyrin 9 in cancer cell. After this waiting period, we will remove the dressing, we will remove the excess cream, and the surface is irradiated with visible light. This combination is deadly for cancer cell, visible light and photosensitizer. Now our photosensitizer, protoporphyrin 9, will absorb this visible light. Absorption will be peak at 410 nanometer. This is nothing but Soret band. All these things we will deal while dealing porphyrias. Now visible light wavelength is in between 400 to 700 and the components are VIBGR, V for violet and R for red color. Violet color will have less wavelength, so it will penetrate less, 1 to 2 mm only. Red color will have highest wavelength, long depth of penetration, 6 to 7 mm deep. What are the light sources to emit this visible light? Polychromatic light sources. Tungsten filament, xenon arc metal halide, emitting 630 to 635 nanometer. This is the wavelength of red color light. Here you can see red light is having long wavelength 630 to 635. Violet short 400 to 500. We all know wavelength is directly proportional to length of penetration, inversely proportional to energy. Next, lasers, diode, intense pulse. You can just remember polychromatic light sources, lasers, LEDs, light emitting diodes. These are latest, cheap, compact, easy to maintain, which delivers uniform irradiance up to 20 centimeter. Irradiance is nothing but throwing light on the lesion. Coming to indications, we got photosensitizer, we got light, where we can use actinic keratosis, Bowen's disease, superficial BCC. Remember this word clearly, superficial only. Remaining all other BCCs, it is contraindicated. Why we are using topical cream only? Superficial BCC is just a patch, so we can use. How much light we have to irradiate? 37.5 joules per centimeter square. In lasers, we have already understood what is fluence, nothing but energy delivered per unit area. What is the unit for measuring energy? Joules. Here you can see clearly joule per centimeter square, energy delivered per unit area. How much fluence we are applying? 37.5 joules per centimeter square irradiance. 2 sessions, 1 week apart. And review after 3 months, 6 months and yearly to see any recurrences. Where else we can use genital warts? Granuloma annulare, localized cutaneous B cell and T cell lymphomas, vulval and penile intraepithelial neoplasias, cutaneous leishmaniasis, necrobiasis lipoidica. All are superficial lesions only. See here, cutaneous leishmaniasis. Only for superficial lesions we can use. Coming to contraindications. Xeroderma pigmentosa. It is already a photosensitive disease. If you apply light, it will aggravate. So it is contraindicated. Common sense. Next, porphyrias. We are already using porphyrins as a photosensitizer. So absolute contraindication. And diseases with metastatic potential like invasive squamous cell carcinoma, melanoma. Invasive. If it is invasive and metastasizing, what we can do with treating only superficially located lesions. Next, highly pigmented lesions like again melanoma, pigmented BCC. Melanin will interfere with absorption of light with photosensitizer. Next, thick tumors like nodular BCC, morphic BCC. Here you can see all variants of BCCs except superficial BCCs are contraindicated. Midfacial lesions. After procedure, we will advise patient to keep away from sunlight 1 to 2 days. Why this 1 to 2 days? We all know it is the time we give to photosensitizer to clear from the body. Coming to adverse effect. Acute adverse effects: erythema, edema, exudation, itching, pain, ACD secondary to prodrug, urticaria, ulceration. These are all easy only, we can write all acute adverse effects. Next, chronic: scarring, milia, pigmentary changes, hypo or hyper. Other types of topical photodynamic therapy: ambulatory photodynamic therapy, which uses ambu light. It is nothing but a portable, small, battery operated light source which can be tied using a pelt. It will cover small diameter of 2.4 centimeter. Our LED is 20 centimeters. It is for small lesions. can be used at home and work also without interfering the daily routine. We can do our work as usual with the help of this ambulite. Same daylight photodynamic therapy. What is daylight? Nothing but sunlight, which covers large areas. Can be used for actinic keratosis, but only thing is we have to apply sunscreen with SPF 50 plus minimum. Why? If we apply sunscreen, light will be blocked. No, why you are using sunscreen? Because sunscreens will block only UV radiation. Here we don't want any adverse effects from getting exposed to UV light. Only visible light we are using. So sunscreens will anyway allow visible light. So we have to apply sunscreen and then go and expose to visible daylight. This is nothing but daylight photodynamic therapy. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.